Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will address drug prices, access, and affordability in the U.S. In just 1 year, prices for more than 4,200 prescription drugs increased on average by 15.2%. I'd like to briefly introduce our speakers. Gerard Anderson is a professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Mariana Socal is an associate scientist in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. We will have time for questions following our speakers' remarks. We will take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to all panelists and hosts. Please enter your name, media outlet, and question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing, and it will be recorded. Dr. Anderson, please go ahead.
Well, thank you for this opportunity to talk to so many people that I talk to quite frequently. It's a great honor to be here today. I was asked to talk about 3 issues in the introduction. The first one is march-in rights, which essentially is in the news again. It's been around for a very long time. It allows the government to take away a patent from a drug company and give it to a generic company to manufacture it. Originally, it was designed to help the Defense Department, because if there was a particular drug that was important for national security, then it was a drug that we wanted to make sure was available and wasn't controlled by a drug company on patent. We saw this being looked at post 9/11, when there were some drugs that were very important for infectious controls, and there was a threat to use march-in rights. Now it's more the fact that the federal government has put a lot of money into drug development through the NIH and DARPA and other places. And the question is, should they be asked to pay such a high price when they've done a lot of the basic research in that particular area? We've been working on drug negotiations for the past 3 years, and our team at Johns Hopkins, and it's exciting to see the legislation actually pass and the first set of drug negotiations being discussed on February 1st. We've been working with CMS and others to try to figure out what should be the initial price. It turns out to be a very difficult, challenging issue, because you've got to look at comparable prices and which drugs are in fact comparable drugs, which ones have the same therapeutic equivalence. So that's a big challenge for there. When the legislation started discussing, it was called Build Back Better. It was the legislation that passed in the House, and they looked at the prices in the United States vis-a-vis other industrialized countries. We wrote a paper back in 2019 that took a look at the prices in the United States and in Canada, in France, in Germany, and other industrialized countries. And for brand name drugs, we saw that they were 3 to 4 times more expensive than in the United States. And so we said, well, we should bring those prices down to comparable levels in other countries. Why should the United States pay so much more higher prices than other countries? So those are the 3 questions that I was asked to take a look at, but we study a whole variety of other questions and would be happy to answer questions on a variety of different topics.
Thank you, Dr. Anderson. Now we will hear from Dr. Socal. Dr. Socal, please go ahead.
Hello, everyone. It is very exciting to be at the start of 2024 and having this conversation with you today. 2024 is going to be a very, very interesting and exciting year for prescription drug access and affordability in the United States. There's a series of elements and changes in our market that will help expand and advance access and affordability of drugs in 2024. At the federal level, the Medicare negotiation, Medicare drug price negotiation program, negotiating the price of 10 drugs that represent the highest cost. The 10 drugs alone represent 20% of the prescription drug spending in the Medicare Part D program, will help bring down the prices of these very important drugs. Together with this policy, there will also be a cap, a maximum that Medicare beneficiaries will spend out of pocket to obtain their prescription drugs in 2024. That did not exist before. It's the very first year that beneficiaries will have a maximum and that they can expect to pay. And these two policies, they benefit mainly Medicare beneficiaries, but there's also a policy that will benefit everyone, which is a penalty for drugs that raise their prices faster than inflation. So that's also the first year that this penalty will be implemented and trying to discourage manufacturers from increasing drug prices. At the market level, insulin manufacturers have already responded, having announced steep price cuts for insulin products at the very outset of 2024. Some prices have been reduced by more than 70% as compared to previous years, which has been a first in many, many decades for these products. And finally, also at the market level, we have seen an incredible increase in the number of biosimilars available in the US market and the adoption of these drugs. Biosimilars are less expensive versions of branded biologic products. Biologic products are very complex, high-cost drugs that are used for chronic conditions. And biosimilars offer savings, and this is the first year that we are seeing a wider adoption of biosimilars, especially for drugs like Humira, who used to be a #1 blockbuster drug for over 20 years. And we will watch intently what happens to the market of these drugs and if patients can get lower prices. Unfortunately, on the flip side, there are also factors that may hinder and further challenge access to drugs in 2024. #1 being drug shortages that have already been a problem in previous years, ranging from common drugs like Tylenol to very serious drugs like chemotherapy to treat cancers. And also the issue of pharmacy closures that has tended to disproportionately affect communities that already have disadvantages and already challenged in accessing prescription drugs, and also communities that have a higher percentage of minorities. So these are all of the trends that we will be watching and monitoring in 2024, and happy to share with you today.
Thank you, Dr. Socal. Now we will take questions. Again, a reminder, if you do have a question, please enter it in the Zoom chat addressed to all panelists. So the first question comes from Karen Landman at Vox for both panelists. We'll start with you, Dr. Socal. I would love your thoughts on what consumers should do broadly about drug shortage stockouts.
Consumers, it is a very typical characteristic of the United States pharmaceutical market is the lack of transparency and the lack of widely available information. So consumers have tended to have a steep curve ahead to access their drugs when there are shortages. #1, they must talk to their providers, get new prescriptions, talk to pharmacies, figure out where there's still inventory available. Oftentimes, they must change the prescription, get a prescription for a different drug, and talk to their insurance, get prior authorization. So drug shortages are not just a problem of that drug that is in low supply. It's also a problem that affects progressively providers, insurers, and suppliers, and patients. Unfortunately, they need to exert a lot of effort to finding information about these drugs and finding a solution when there are shortages.
Great, thank you. Go ahead, Dr. Anderson.
So your physician, your hospital is very closely monitoring this. The Food and Drug Administration is monitoring where there are drug shortages. So this is something that we've been working with the White House and the Congress on as an important issue. So I think we're working on it, but it is a problem. What you got to recognize is where the problem typically occurs. It typically occurs at the production level of a drug company. It can be a generic drug company or a branded drug company, but most of the evidence suggests that it's when a plant has to close because it doesn't pass FDA standards or some other reason like that. So a lot of the drug shortages are the result of the drug company's inability to produce enough drugs because of some closure or some change in the supply chain.
Great, thank you so much. Here's a question for both panelists. This is from Tammy Labie at CNN. How much will negotiations lower drug prices for those using the meds, for Medicare generally, and for the US overall? Dr. Socal?
Excellent question. For some of these drugs, the Medicare prescription drug plans that are insurance plans that operate the benefit for the Medicare beneficiaries, in many cases, the plans are already paying a low price on these drugs because of rebates and other discounts that the plans have been able to negotiate. But typically, these rebates and discounts are not available to the beneficiaries, patients themselves. When patients are required to pay, for example, a percentage of the drug cost, which is very frequent, even in the Medicare space, it's typically because they have a co-insurance, which is common for a specialty high-cost drug. If a patient is required to pay a 20% percentage of the drug cost, they're paying on a price that has not been discounted or rebated yet. So specifically for patients, having a negotiated, publicly available maximum fair price, even if plans are still paying potentially the same or very close to discounted prices that they may already have available today, for the beneficiary, that will make a big difference. Because in certain cases today, beneficiaries paying a 20% co-insurance on their drugs, the plan gets so much rebates and discounts that maybe that 20% is more than what the plan is actually paying for the drug. So there will be more transparency. And I believe that the number one individual that will benefit is the patient and the Medicare beneficiary.
Great, Dr. Anderson?
So I'm on the Maryland Drug Affordability Board. Mariana Socal is on the New Jersey Drug Affordability Board, and we will be setting what are called upper payment limits, or the amount that residents in the state of Maryland, for example, will have to pay for certain drugs. And so we can set a price for the drug, but we're not sure how that will flow through the system. It could be that the price goes down to the consumer. It could be that the price does not go down to the consumer. So we're trying to lower the prices both for the insurance company and therefore lower the premiums for the individual person. But we're also recognize that many of these drugs are very expensive as an out-of-pocket expenditure. Some of these drugs are $5,000, $10,000 out of pocket. And if we lower the price for the drug, we hope that it will lower the out-of-pocket price for the drug for the individual consumer, but we have to see how that works through the system. The same thing holds true for the Medicare program. There's no guarantee that it will necessarily result in the Medicare beneficiary paying less out of pocket. It could be that their premiums go down, but the person will not see an actual reduction if they're taking that specific drug. So that's something that we have to watch, how it flows through the supply chain and the prices for the supply chain.
Great. Thank you. And for you, Dr. Anderson, here is a question from Len Peterson at Trends in Medicine. Are you worried that price controls negotiations will or already are reducing investments in new drug development?
So we are definitely concerned about that and trying to monitor what's happening in the industry. We cannot tell you whether or not a new drug will or will not be developed. There are so many factors that influence drug development. What the NIH invests in, where the venture capitalists invest, whether or not there are new scientific discoveries. So, for example, a lot of the cell and gene therapy is the result of new scientific advancements. We couldn't have predicted that, and I don't think anybody else could have predicted that very well. So we're not looking at, are there new drugs entering the market? What we're looking at is there money for new drug development? And we're really focusing on one aspect of the market, and that is the venture capital side. We believe that the venture capitalists are the canary in the coal mine. They're the ones who start most of the research and development. Most of it starts in an academic medical center, gets translated into some kind of early development product that is done at a venture capital firm. These firms could invest in healthcare and could invest in biopharmaceuticals, or they could invest in something else like IT or transportation or anything. So they're looking to get the maximum return on their investment. And if they don't think that the biopharmaceutical industry is a good investment because of any of these reforms, they will not put their money into it. So our focus is on whether or not there is money for research and development, not whether or not research and development actually occurs and whether or not there is a new blockbuster drug. That is not random, but that is something that's really, really hard to project and predict.
Great, thank you. Here's another question. You both may want to take it. Let's start with Dr. Socal. This is from Kristen Krause at EW Scripps. Can you talk more about the federal penalty manufacturers face for increasing prices faster than inflation? How much is the penalty? Who is issuing that? Also, what advice do you have for consumers for addressing drug price hikes? Dr. Socal.
Excellent question. The inflation penalty is calculated for prescription drugs that are taken at the pharmacy counter, that dispensed at the pharmacy counter. The inflation penalty is calculated over the course of a full year. So the calendar started in October last year. It will end mid 2024, September 2024. And during this period of time, it will be compared to a benchmark period in previous years. And for those drugs that did exhibit price hikes above inflation, the whole year, the number of units of that drug that was sold within the Medicare program, manufacturers will be liable for that total times the extra price that was on top of inflation. So can be a pretty significant penalty. And the intention here is, I would say, number one, to deter that behavior, and then number two, to penalize those who do. And the penalty is in form of a rebate, which means after the whole year is analyzed and everything gets calculated, that's when the manufacturer is due to pay the penalty to the Medicare program. So that penalty doesn't go directly to patients. However, for example, in the Part B program, that is for drugs that are administered in a physician office or in a clinic, these drugs are by default covered by a co-insurance. So individuals are always expected to pay a percentage of that drug cost. The Medicare program has already announced drugs that did increase prices faster than inflation and has already announced lower prices over which those patient percentages should be calculated. So patients today, all that they must pay to obtain the drugs they need is always determined by their plan, by their insurance, or by their employer-sponsored insurance, or by their Medicaid program or Medicare program. It's always the plan that determines how much the patient must contribute to get their drug. And so we will have to observe whether or not Medicare plans will change what they require, but at least for those cases where these percentage payments are required, we can expect to see some reduction, at least according to the experience that has already happened at the end of 2023, when the first drugs in the Medicare Part B program were announced.
So what is important to recognize is that the drug companies are the ones that initially set the price, and they are the ones that announce price increases. And the price increases for many drugs are based upon the price that the drug company sets. and these are when there is cost sharing for a drug. It's often based upon what's called the list price, or the price that the drug company announces. And when those go up, the consumer's price that they have to pay when they buy the drug can also go up. So the purpose of this legislation was to keep the consumer from paying 5%, 10%, 15% higher prices than they would have paid in the past if you can deter the drug companies from raising those prices, because it directly affects the consumer, especially for very expensive drugs.
Great. Here is another question for you, Dr. Socal. This is from Rachel Kors at STAT. Do you expect we will learn anything publicly about initial offers from HHS and the Medicare drug price negotiation program on February 1st?
Well, one of the reasons why I personally, one of the benefits that I personally believe the Medicare drug price negotiation program created in our market is going to be transparency, and prices will finally be known. Today, Medicare beneficiaries do not know how much they pay, do not know how much the plan pays in total for the drugs. And it is anticipated that the maximum fair price being public will bring transparency to the system. Now, conversations that are due in February 1 are between the Centers for Medicare Medicaid Services, so between the Medicare program and manufacturers. And these conversations are supposed to be confidential as they trade information. Manufacturers must, in response to prices offered by Medicare, they should then provide more information, and there is this exchange in a time period built in to allow for these negotiations to happen, for this back and forth. So it is possible that these prices in February 1 will be confidential and will be limited to the participants in the negotiation. I would also say that most typically, pharmaceutical industry is not very excited about transparency and about their prices being publicly available, because the way that the pharmaceutical market works today is that very, very high drug prices are beneficial to the participants in the supply chain and in the market. Entities such as pharmaceutical benefit managers, even the dispensing pharmacy or wholesalers in insurance plans, everybody typically can make a profit off, of discounts and rebates that are negotiated in this supply chain. So there is a benefit to all these participants of prices not being publicly available. Given all these incentives, I'm very skeptical that we would hear anything about drug prices being public before these negotiations come to a close.
Great.
So,
go ahead, Dr. Anderson.
I've been around for Washington for 40 years, and secrets are not something that people in Washington are able to keep very much. So my guess, Rachel, you and others will find ways to figure out what it is. Either somebody at CMS, unfortunately, will provide the data, or the drug company might argue, can you realize how low a price they initially said that they thought our drug was, and they will use that. So my guess is that by February 2nd, one or all of you will have some information on this thing. We don't have any inside information on what the prices are. We spent a lot of time trying to help them figure out how they should set the initial price, but we're not going to find out what the prices are until after you do.
Great. Okay. Next question for you, Dr. Socal, from John Cummings at Health Leaders Media. Payers, pharmacy benefit managers, providers, and pharma, they're all blaming each other for rising healthcare costs. In the end, the consumer pays the freight. Do you see any effort on the part of these key stakeholders to work together to keep prices affordable for consumers?
That's an excellent question. I would absolutely agree with you that all these different entities in our market have tended to point fingers at each other and blame each other for these prices either going up or remaining up over time. However, it is a strong trend in our market that all these entities have been progressively becoming more integrated with each other, which means that health insurance plans now own pharmaceutical benefit managers that in turn own pharmacies or vice versa. And so they belong, to the same parent corporations progressively more frequently. So the question is, even if publicly they have tended to deflect and point fingers at each other and deflect blame by blaming each other, behind the scenes, these companies have actually more frequently came together to then find lower prices, better opportunities for profit for each other, which has not necessarily resulted in savings to the consumer. So I would say that there's also a trend in some entities, for example, manufacturers trying to bypass the system by offering drugs, directly to the consumer. We saw this recently with Eli Lilly and one of the anti-obesity drugs to try to bring prices directly to the consumer and avoid this whole complexity of the system. So, there are some initiatives, but I would say most frequently, the benefit is happening at the health insurance, pharmacy benefit manager level, and less frequently to consumers.
So there is opportunity. There's opportunity for savings. We've heard this many times that if we combine, we will be more productive, we will be more efficient. But the incentives are just not there. I mean, the drug companies, and as a stockholder in a drug company, I would want them to try to maximize their revenue. Same thing with the different PBMs and everybody. So I think they're all going to continue pointing fingers and doing these things that they have been doing, but that's what you expect, and that's what as in the marketplace you would expect them to do. So I think there won't be any significant changes in the current time.
Great, thank you. A question for you, Dr. Anderson, from Gabrielle Wene at Inside Health Policy. How would the Biden administration and Congress work on drug pricing during this election year?
So I think this is a period of time for implementation. There might be a few things that needed to be tweaked in the Inflation Reduction Act, and that's possible that will happen, but I think it's very unlikely. So I don't expect a lot from Congress in the 2024 period, except for maybe passing some of the stuff that's already been discussed quite extensively over the period of time. But I think anything new, when I talk to the staffers and the members of Congress, they're not expecting any new big ideas to come out in 2024. I think as we look at it, it almost always occurs right after an election. So 2025 is where people are gearing up. So if you're looking for big ideas, you look starting in 2025 for those kinds of activities. For the administration, they've got their hands full in dealing with a lot of FDA reforms and obviously the Inflation Reduction Act and trying to implement it with all the negotiations and all the different things. So I think aside from that, we're not going to see anything major.
Great, thank you. And here is the last question for Dr. Socal from Julie Washington at the Cleveland Plain Dealer. Will the FDA's ruling on imports from Canada make it easier or harder for U.S. consumers to get cheaper drugs from Canada?
Well, importation at the personal individual level has always been a possibility in the United States. If a certain individual has a chronic condition that requires a drug that for some reason is either not available or affordable here, that individual person is allowed to go to Canada and purchase their drug. The real novel element here of the Florida program is that for the first time, it's a state program. So it's the state spearheading this effort to identify the drugs and purchase them and bring them to the state. So certainly there is a potential there for these drugs to be coming up to Florida consumers at lower prices. Now, there are many challenges for this program to actually deliver on these lower prices, some of them being the types of drugs that are allowed There's some very, very high cost drugs, mainly biologics, who are excluded from this possibility. So, insulins and other very expensive drugs that are, that pose very important affordability challenges for patients. These drugs are excluded from the program, and also challenges that can happen in the Canadian side. And we have been hearing about it, and challenges to the whole overall supply that will be available to this program. I think these are factors that we have to also monitor and see what the final outcome will be able to be, given these multiple moving parts of the program.
So I think Canada recognizes that these drugs could be imported, but they want to make sure that they continue to have the low price and the access in Canada. So I think, the Prime Minister is very concerned about too much importation to the United States, because the drug companies know approximately how many of each drug will be sold to the Canadian consumer, and they don't want to make additional drugs available for export to the United States at a significantly lower price. So you have the Canadian government opposing this idea. You have the pharmaceuticals companies opposing this idea. It's unclear whether or not the wholesalers will be willing to transport drugs across the Canadian border in large quantities to Florida. So I think there's a lot of things that make this a real challenging idea. Also, Colorado is trying to look at this issue, and a number of other states, but I think it's going to be very hard to implement.
Great. Thank you both for your insightful answers and your presentations. We will email the links to the resources mentioned today and share it in the chat to all of the participants. And with that, I'd like to say thank you again to everyone for joining us today.
Thank you.
Bye-bye.